As we're waiting for people to come into the room, we'll just get going with some housekeeping. So we just move the slides on. First of all, we want to thank some of our sponsors that have helped us run this event. We've had a really successful week of patient partnership events, Sir Jim, that you'll have seen that have covered a range of different things, and some of those things we'll be talking about today. There's a couple of other housekeeping. The chat box is open, so please do say hello to each other in there, because it's really nice for me and Jim to know who's in the room. And the closed captions function has been enabled for those of you who want to use it. And I think the rest you can see there. So I'm going to introduce Jim in a second, but and we're really grateful for you, Jim, for coming and doing this. And we know how busy it is, because we didn't realize when we booked this in that we would be on the eve of the launch of the 10-year health plan. And, you know, so this is a conversation, a real pivotal time for patients. And I know that you've talked about this in the past, the public satisfaction with the NHS has reached an all-time low of 21%. And we're seeing major structural changes as the NHS England is integrated into the department. And then we're hearing from patients daily through our free phone helpline, and from a lot of the work that we do through surveys and focus work, is about their daily struggles, not being able to see a GP, waiting and paying for treatment with elective lists so long, feeling unheard when things go wrong. And I know that you reflected on that at the weekend when you said sometimes the NHS can be deaf to criticism. But we're also hearing some really exciting stuff coming out of you and the Secretary of State around your vision for getting back to basics and creating those conditions for success. We have the Secretary of State for Health and Social Care talking about power to the patient. And I suppose we want to really understand what that means in practice. So today's questions came directly from patients, carers, and the public who've registered for this session. And you can imagine we were inundated with some really good questions. So I'm going to start asking you questions now rather than me talking, because people are here to hear you. So Jim, we know that, welcome first of all. We know that you bring significant experience in health system transformation, and we're hoping that this conversation can help build the kind of genuine partnership between patients and the NHS leadership that you and I both agree is essential for success. You've spoken about getting back to basics and the conditions needed for success. What does back to basics mean for rebuilding that fundamental relationship between the NHS and patients?
Thanks, Rachel, and good to be here as well. It's a complicated time with a plan, as you say, being published tomorrow, but really good time, because I think a big powerful element of the story in the plan is about patient power again, and just reconnecting and on that, you know, getting back to basics as you've described. So this if we're honest, often in healthcare we get very attracted with the big technology, the big innovations, the robots, the AI, you know, the new drugs and treatments, and they're all absolutely necessary, and we're very lucky to have them and continue to want to develop them. But we know from interactions with our families, with patients and families, it's usually not that. It's usually not the technical stuff that people feel let down by. It's waiting too long, first of all. But being left waiting without any communication or any idea about what's going on, stuff you and I have talked about a lot over the years, confusing letters, changed appointments, lack of human interaction sometimes, feeling like you're in a production line without feeling like there's a human acknowledgement. Colleagues hadn't the time because they were run off their feet to understand and pick up on your anxiety, talk to a family member, engage with a family member. So a lot of the basic stuff, it's not in some setting, if I was talking to managers, a lot of this is about the administrative processes, the booking processes, the letters, the appointments, the scheduling, you know, those sorts of things. So it can mean lots of things, but they're often the things that are where the value is. It's reminding ourselves that it's a human system, it's not a machine.
Yeah, absolutely. And I think that human interaction, and I get, you know, we got that through the pandemic, that that staff were so busy sometimes, and that sometimes we forgot that, you know, that really important question about what matters to you, that shared decision making, somehow got lost in the process for a lot of patients. And I know it works well. There's some fabulous frontline professionals out there. How are we going to get that back though, Jim?
So I think the first part of this step, and I'm saying this as a terrible introvert, is we have to talk about it and socialize it first of all. We're not going to be able to get where we need to be and where everybody wants to be until we've actually started talking about, you know, the elephant in the room, the things that we've lost focus on because everyone's so run off their feet with other things. So we are in a phase where at least let's talk about it. Let's openly discuss it. Let's exchange our perspectives on it. Then we know this works in the NHS, working now in the NHS. It's working, it can work in the same team at times, but not consistently. It can work in the same hospital perfectly, but not consistently elsewhere. There are some parts of the NHS are doing it really well, others are really struggling with it. So the thing we have to do is try and introduce that consistency and systematize where we can, but learn from each other as well. You know, one of the powerful things, and we're all for various reasons reminiscent about COVID and stuff at the minute with inquiry and various other things. That period of extreme rapid innovation at the beginning where people were learning from each other about what worked and what didn't work and kind of pulling together and stuff, that was really valuable at the time. So we have to talk about it, acknowledge,
Yeah.
accept where we are. We're not where we want to be. And then that's a gateway to being able to start understanding it better and addressing it. And the addressing the issues then I think that's where the conversation's necessary, where the structure's necessary to get the right data intelligence, the right detail and the specifics that relate to you and your team and might only relate to you and your team versus things that are organization or
Yeah.
system wide. And I think the problem with a lot of this, it sounds really complicated, it sounds hard work. People are really run off their feet, and they are. There's a lot of complexity. Patients are more anxious because they've waited longer and various other things that are going on. So it does feel harder than ever to actually deal with it, but we have to make a start.
So absolutely, and I'm hoping that when we all see the long-term health plan tomorrow, we will see that, and we know that the Secretary of State is talking about power to the patient, and I was reminded this week about Bevan and one of the statements that he made, which was around something about like when a bedpan falls down in Wales, it'll reverberate in the department, and that people's complaints will be listened to and patients will be heard. And you talked about that at the weekend as well. How, with all the change happening, are we going to make sure that that patient voice is embedded in the new ways of working, both within local systems and the integration of NHS and the department?
With all the changes that we've got going on, one of the things we keep coming back to is what do we need to do centrally and do it, you know, just do what you have to do centrally. Don't over intrude, but do what's necessary. So there's a bit about direction setting, you know, being clear on expectations, rules, frameworks, things that can support delivery. But this is something that everybody needs to grab hold of, every organization, every board, every chair, every chief exec, every non-exec director. We're expecting people to have heard the message, and they have, and I've talked to a lot of colleagues over this last few weeks who are in agreement that we've got a lot to do and enthusiastic about what can come from this if we'll get it right. What it won't be is a set of central instructions that will immediately mean we provoke an ab reaction by being over directive about what people do. We have to hope, based on the evidence, that leaders, frontline clinicians, frontline managers actually really care about this because they do, and that's why they're doing what they do. We've just made we've allowed the system to become very complicated and hard to do the right thing over this last few years. So what we'll be saying, and there's various things, 10-year health plan, Penny's report, various other things, they'll signal patient experience, patient power, patient engagement are important things. So first of all, if you're running an organization, accept that, do something about it. What you do might be different to the place next door.
Yeah.
You know, and then also, I honestly think one of the really key components in this is curiosity. We understate the value of curiosity. I've worked with fantastic people throughout my career, some really brilliant chairs, for example, who wouldn't accept what was being told them in a good way. They wanted to know more, they wanted to get behind the data, they wanted to talk to people, they wanted to walk the floors, they wanted to talk to patients in waiting rooms. They wanted to see complaints letters, you know, those sorts of things where all the richness is. So
Yeah. Yeah.
that's where, but you've got to have the curiosity, want to do that. And frankly, you've got to be willing to hear what you don't want to hear. And some of it, so I remember when we embarked on this in Northumbria and we appointed Annie as the patient experience director in 2010, we did quite a bit of warming up with the board, the senior team, senior clinicians, etc. about we're going to hear things here that we might not want to hear, but the things that the population's actually already talking about. We're just not
Yeah.
hearing them.
No,
So
no. And you and I spoke about this when we were sitting on the elective recovery task force during the pandemic. I think the
yeah.
word curiosity is something that would be really good to see, that the culture of local systems really has that curiosity. And I remember when we were talking about people, why maybe patients didn't turn up to appointments, you and I and Stella were talking about the need to show that curiosity, not to just treat it like a did not attend, which immediately puts blame on patients, rather than it is a missed appointment and what can we understand more. But the NHS is such a huge machine, and I completely get that you get the culture of curiosity, and culture comes from the top. But when we talk to local patients and we hear from patients through the helpline, or, you know, we've a lot of Health Watch on the call today, and you can see some of the questions coming in there about the work that they do locally, that kind of humility and that work that they do locally with patients. How are you going to make sure that that kind of work maintains at a local level?
Mm. I mean, the honest answer, I was off today. I'm not completely sure, but you're right. I've worked with great Health Watch colleagues over the years, really cared about what they were doing, had good systems, processes, were trusted, regarded as part of the local health family. But the changes that have been announced. We have to make sure that, as I said earlier, we're clear on expectations centrally about engagement in every form, having a curiosity, having a system, having an approach, and then working with whatever that local infrastructure is that can help capture that patient voice, that community voice. It will
Yeah.
have to find local ways of getting those things built to support what we need to do.
Because we can see, you know, we've seen some of the stuff in, well, HSJ really around the NHS app and the role of the NHS app, which obviously, you know, is a great piece of work, and we know lots of patients who really enjoy it, but that human touch has to remain, because we've been talking about that earlier in terms of technology and big technology, but making sure that the basic stuff works and that we're talking about it.
Yeah.
One of the questions that was coming in from patients a lot was that sometimes it felt that, so specifically around the roles of local groups and patient participation groups, and it was described as, how do we move beyond that window dressing?
Mhm. That's a great question. When you're talking there, I'm having flashbacks in different points of my career and different iterations of CHCs and health watches and patient forums and various things. I think a lot of it comes down to the leadership. I mentioned chairs and boards earlier. I've had generally throughout my career chairs who really believed in that. They really felt the need for us to engage with whatever the local intelligence was, the local part of the infrastructure in the community that had had a perspective that we needed to hear. They were often embedded in the board. You know, there'd be board observers, there'd be another decision-making processes and quality committee as an observer, maybe part of patient panels, you know, those sorts in different ways where,
Mm,
but next door had a different way of doing that. But I think the spirit has to be that you have the intention of enabling and allowing people to give you that perspective and hear it and take it. But I think in enacting upon it, one of the phases that we're in though is to moving away from that being very, very heavily specified centrally and saying there's only one way this can be done and this is it. You know,
yeah.
tell us how you've done it. Because if we're honest, that's not really worked for us in the last few years.
No.
We have to lean into the fact that it's just very different, different parts of the country. And we do also want to see it more of a movement where people really want to do it. And they're not doing it because we've given them a template to fill in. And by not giving them a template to fill in, they've got more time to spend on it and actually do it and work with people to do it properly.
No, absolutely. And I really like that. I really like the really want to do it, because I think all of us in organizations sometimes have to do reporting. You know, through my career as well, I've had to write reports to go into my boards, and not so much the patient association, because my boards just want to know about the impact that we're having on working directly with patients and the difference that we're making. But it can be quite hard if it doesn't feel genuine. And I think
Yeah.
you're right, because I know when we spoke before, you talked about Newcastle and sometimes getting letters from patients and just coming into you. So how did you get your board to really see that patient outcomes were so much more important than us listing the activities that we've done?
So I was going to say it's never been a struggle. I've never felt I had to force that or had people engaged in the board who come to that bit and they think, oh, here he goes again, or here we are, here's the patient experience report. It felt natural. That's an oversimplification because there was a lot went into board selection.
Yeah.
From the chair, the processes with the chair, increasingly with governors and other parties about have we got the right skills in the room, as well as have you got the lawyer, have you got the accountant, have we got people who are interested in community, who are interested in customer service,
Mm-hmm.
who have the required curiosity. They're going to understand data, but they're going to interact with people. And then also then creating the system and the structure and the mechanics to support the activity. So it's not just kind of aimless intent. There has to be a bit of science that comes with it all. So this is actually, I think, more technically complicated than people think as well. So it feels like you can just do it well or you've got good spirit. But it's like everything you need purpose and method to
Yeah.
be able to get where you need to get to. So I am really fortunate because I've never had to have an argument with anybody in board or in a senior team about having the time to talk about these things.
Right.
But I am probably then by saying that doing a disservice to chairs and other colleagues who'd made sure we had the right people in the room.
Yeah, and the right people in the room is really important. And I think my reflection on that as well is around kind of the values of the NHS. That's what the NHS is there to do. So, and people in the questions that came through, and I think we had about 140 questions, which we're obviously not going to get through in the hour that we have together. But I've tried to theme them as much as I possibly can do. People are asking the kind of fundamental questions about NHS transparency, and you did touch on it.
Yeah.
And you know, they were saying, you know, why can't we get clear information about how long they're going to wait? And I know you and I have had this conversation. Access is so different in different areas and why they're concerns. So you've talked a lot about your vision, you've talked a lot about the spirit, you've talked a lot about the need for data to be in the place. How, as Chief Executive of NHS England, are you going to make transparency a lived reality rather than that aspiration that I know that you believe in?
Yeah. So there's a couple of angles on that. So in this next super stats, we'll publish a little bit more data than would normally publish. So the intention is on key performance metrics, we'll produce some new tables that will show how organizations are performing. And that's the start of a commitment to say, we're going to build this out. We're going to start producing stuff. We've been working with colleagues across the service to say, look, this is important. It's an important part of accountability. We should all work on the basis of, over time, as much as possible, being publicly accessible and being shared publicly, but also being shared in a way that people can actually understand it as well. So, sometimes I'll look at some of these things and I'm an accountant by profession. You could spend 10 minutes working out whether a table's upside down or not sometimes, just trying to make these things actually accessible is a bit of a skill. But the intention is then we'll start from this next superstar to start pushing stuff out and also sharing stuff more directly with the NHS community, because it's been hard to see how people do relative to others. And that'll flow in every domain: money, performance, experience, quality metrics, you name it. When you and some of them then we'll open up as well a public version of this, using the federated data platform. Again, in the next few months, colleagues are working on this now. On transparency, I just want to land one point. Transparency is a thing that can't be selective, right? So once we say it's transparent, even when it tells us something we don't want to see. Well, yeah, that's where the learning is. So I've been in environments over time where it's all well and good when things are going the right way, and then people want to feel less transparent when it's not going the right way. So we can't have that. This has got to be objective, warts and all, one-way street. We can't stop once we've started, kind of thing. But then also on some of your specifics, so the thing we've talked about before about waiting times, it is actually quite complicated how you define what is that data actually saying. Is it an average? Is it the mode? Is it what's happened, or is it what's likely to happen? Etc. So we do have to, I think, start publishing stuff, explaining the basis on which it's produced, and then over time refine it and explain it more. But the point is, when it's accessible, and I've had this experience, then when you've got that public voice from scrutiny committees or from a local MP or a community group to say, why do you wait 3 weeks longer here when next door it's much quicker? And then that's something you can use. Then you feel accountable for sorting it out, and clinical teams will respond to it as well as they've got confidence in the data. So this is a journey we're going to have to go on, and it'll take a while to feel like we're really on top of it. But it's also, as I said, it's not something we'll do for a couple of months and then stop.
No, and I think that's I've been saying this to NHS England for a long time, that if we're honest about when things are going well and we're honest about when things aren't going so well, then we can do that genuine partnership with patients and communities, because actually we all want it to succeed.
Absolutely.
We all know that the NHS is loved, but when you're not feeling listened to, where you're seeing things like epidemic injustice happening to patients, where their stories are disregarded. So I really value the fact that that's what you're moving towards, that transparency, be it whether it's good or bad, that we're going to know it and we work together on it.
In the other dimension, which I think is really important, especially when you look at maternity, problems in maternity, Rachel, really in a really tragic kind of context for the people involved. It looks like we've really not been hearing what's actually been going on. We've not really been trying to meet people when something's gone wrong, hear them. It's hard. It's painful. I would argue it has to be, because you've got to feel the pain of doing these jobs to be able to do them well. But also you can see also big organizations, publicly funded, something goes wrong, somebody talks to the lawyers, they talk to the insurers. Before you know it, everybody's saying you can't say something. Even if your instinct is right, and we are socializing with the leadership community to say, let's not do that. We'll take more risk. Let's not immediately take legal advice that will say, don't talk to anybody. We've got to do it carefully, and we've got to respect privacy and dignity and all those things. But to try and get back to just human contact at a time of extremis when the least we can do is to talk to people.
Yeah, no, and obviously we had Sir Robert Francis as the president of the Patient Association, and that was very much what he was advocating as well, about talking to people. The one thing I think sometimes when we're trying to measure patient experience, is that sometimes we measure the system pathways rather than the patient pathways. So as a patient, you go in through primary care, you might end up in secondary care, you need a bit of advice and guidance in the middle of that, then you go back into primary care. In that kind of transparency and those super stats that you're talking about, is there a time that you would get to kind of measuring the patient experience through the system rather than the system's way of working?
Yeah, absolutely. And we're going to have to, so when we're talking about neighbourhood care, for example, in the 10-year plan, we spent a bit of time talking to colleagues today about this. That is all about people working together across organisational boundaries and thinking about the patient, and the fact that by the time you see the patient, it might have already gone wrong because their interactions before that haven't been brilliant. And we all have to own that. And it shouldn't be blamey. It's not critical or institutional dominance or whatever. Try and work together and think about how that works in the round for the patient. This is stuff we haven't done well for a long time. So we're going to have to build a lot of these systems again and the mechanics and getting people working together, and then you come back to that curiosity thing of just trying to hope people will be wanting to know what it's been like overall.
Yeah.
And I had shared with me this morning from Northumbria, where I used to work a while ago. They every year they do it's a version of the British Social Attitude Survey. It's not exactly the same, but it's a version of that, where it's for people's experience of the health system, not just the bits that Northumbria produce. And there's always value in that. So some of it, I used to read it and think that's something I have to fix. But then there's something there, actually, I need to talk to this other party because we're clearly not working together as well as we should be. And the public are worried about it. So again, there's lots of that happening in the NHS. There's lots of these things happening. We're just not doing it as systematically and as consistently as we need to be able to move this as quickly as we want to.
And I think, and I'm gonna dig in one area because it's coming up quite a lot in the chat here, and I agree it because we hear about this quite often within the helpline. But and you talked about the legal, things becoming quite legal, but quite often, and it is quite often when people feel when something has gone wrong, the lessons aren't learned, and families fight the system rather than being supported by it. So, and I think people in the chat box are saying, look, the complaints process needs to be just torn up and started again. But what kind of systematic learning? How can we rebuild people's trust in the complaints process? Hopefully that they don't have to get to the complaints process because your vision is so clear about where you want us to be working directly with patients.
So in my experience, often organizations get too focused on following a process that's been signed off, assured, accredited. The NHSLA and whoever else, NHSR are happy with it. Board committees are happy with it, but miss the fact that that actually doesn't work for the patient. So we might comply with the process, but miss the point. And I've seen that in real life. I've felt the pain of it. So engaging with complainants first of all about how has this worked for you? What would work from a policy perspective? Making sure you've got a complaints process and policy that fits the needs of people who've been through it, because you've addressed some of the issues that they've shared. So there's a bit of engagement in the production of it all. That's hard to do because everyone's got established mechanisms, but there'll be nowhere where it works perfectly. And but there's a risk in changing it. There's a risk that you might then end up with a liability later on that you could have not had a liability for. I think we just need to manage that and kind of, you know, get over it. But the key is listening to people about what it's really been like. All the evidence, though, throughout in my 30 odd years is the thing that hammers all of these processes is very rapid human contact. So something goes wrong, knowing a human being can talk to another human being. They might drop an email into an inbox or whatever, but they're quickly getting a response, somebody picking the phone up who's quite close to the service. I'm really sorry. What can we just talk about what's going on? And the power of that, I mean, it just sounds ridiculously simple. It saves a huge amount of anxiety and work and cost and disruption, by just getting to the point really
Yeah.
quickly. It doesn't work all the time, does it? And sometimes people are unable to have that kind of open communication, and sometimes, you know, they might be very unwell and you know, they can't express what they need or want to express. But most cases can be really quickly resolved just by that. And we, again, in my trust life, would really encourage all the time, senior nurse, a matron, ward manager, ops manager, whatever, something goes wrong, just talk to them, ring them up, talk to them. You might end up at the end of that conversation say, look, this is really complicated. I need to go into a proper process and investigate it. But when you do it, I think everyone's a bit surprised at how many of them get resolved quite quickly. Because most people are reasonable. You just want to know that the person on the other end has heard it, they've done
Yeah.
something about it, and it's, you know, it's not going to happen to the next person.
And so I think, you know, the curiosity conversation that we had earlier is very, very valid within the complaints handling as well. But I think what's also very valid, and we talked about culture earlier and the values of the NHS. But I suppose sometimes we hear when you talk to frontline staff about feeling safe enough to accept and acknowledge that a mistake has happened.
Yeah.
So how are we going to build that philosophy of care? Well, how are you going to build that philosophy of care for staff so that they
Mhm.
feel safe to be able to have those conversations with patients?
I was talking to a young clinician a couple of weeks ago about partly this, and it was sort of partly about backing them on innovation and stuff. And he was really clear that he felt he could do more, could be more innovative, um, could do more for his patients, but he needed to know the organization that he's back. And as long as he wasn't doing stupid things or doing things with bad intention, sometimes it'll go wrong. And I think a lot of this relies on that local belief. So it would be something that I can't solve nationally, but local clinical teams knowing that their local leadership are with them. And as long as they behave sensibly and respectfully and they're trying with good intent, sometimes some things will go wrong, and that's learn from it. Don't hang somebody out to dry. Don't, you know, end somebody's career because of one mistake. And it's more complicated now than when I came into my career. And I remember mid-career meeting a geriatrician on the point of his retirement. He had his first complaint a few weeks before he retired. One complaint at the end of a geriatrician's career. Now, I mean, now honestly, you'd have the first one within a week probably. You know, they're very much more regular occurrences. So there's a shift in society. People were much more accepting of things in those days. Expectations
Mhm.
were different. So you are opening yourself up to this more, but it is where all the learning is as well. You know, if you're
Yeah.
a hungry clinician and you want to be, because generally clinicians are pretty competitive to be very good, it's probably where the improvement is.
Yeah, no, absolutely. And I think we probably wouldn't need to say, well, you know, Martha's Rule is a fantastic thing, but if you look at the kind of structure of what happened there, people not listening to each other, people not communicating to each other, if we're listening better and working better. So yeah. So we know that there is, you know, the public and the patients on uh the public and patients were asking about access issues and how they'd be able to see healthcare professionals in a way that works for them. Now we know there's a long-term health plan coming tomorrow, so we're hoping that's all going to be in there, and I'm trying not to ask you any questions about the specific long-term health plan. But what we do know is that access is really bad in deprived areas. We know, and we know that the Secretary of State did a speech in Blackpool last week that I was at, and we worry, and he talked about the Carhill formula. We're not going to go into that because that's quite a fun, it's quite a systematic thing. But how are we going to, and we did a piece of work with the British Red Cross, and we've just completed a bit of work on social determinants of access as well. And somebody will probably put a copy of the work that we did in there around, patient preparedness and actually how to get the information that you need. How will your back to basics approach address that fundamental inequality?
That's a really good question. And I obviously don't live in a deprived area now. I was brought up in a very deprived area on the banks of the Tyne, and everybody I knew had none of us had any money, So I get the deprivation thing chimes with me. We're all really happy, by the way, but nobody had any money. And I hear the NHS talk about inequalities in quite a complicated way. I've found myself at times talk about inequalities in a very complicated way. But it is about knowing your local data, having the data to determine where you should maybe have more attention on particular segments of the community, and make sure you're tailoring services and access to get them what they need. It's partly what I was trying to say in the Telegraph the other day, that for many, when they're already busy, they will be thinking, why do I need to find more patients? Why? I'm already busy. I can't see them all now. And I get that. But actually, if we can get on top of that, in future, there will be less of a burden because we're finding people at the right time, etc. So I really want us to get out of the phase of talking about inequalities and making it real and really back as something that we're actually doing. Now, one of the things we will do, and Wes was talking about it last week, is we're going to get back to some of the formulas, use the allocation formula properly, redistribute some money that's being distributed currently on the back of deficits, and target that more towards deprivation. And that's going to be hard because it'll mean that we have to spend less on other things, but it's a justified intention that we'll follow through on. That should then start putting more resource into places where they've got a lot more deprivation, can then start building some systems that enable them to start supporting it properly, and changing care models so that it actually looks after those people. And then also when I'm arguing with people about performance and the hard edge of performance, 4-hour waits and RTT and all those things, people often we talk about these things as though they're not connected. It is the most vulnerable in society who wait longer.
Yeah.
They haven't got the advocacy to be able to push themselves to the front of the queue in ED, and when staff are busy and seeing other people, they're not going to be pushing themselves forward, and or if they're being on a waiting list for a diagnostic, they haven't got the infrastructure to be chasing that up and getting themselves brought to the top of a list. And well, like those things happen. They're natural human nature. So again, let's accept that and accept it and understand it. It's a thing. We have to compensate for it, and we have to try and deal with it.
Yeah. So I think for me, it goes back to power, doesn't it? An agency, and you and I did when we worked together back around the time of the pandemic. We were looking at patient choice, and patient choice is really, really important. We know that. But it's about that power and agency. So how, as NHS chief executive, and trust, power, agency, and trust. And so how will you make sure that we're working with people? So there are a lot of very good, small, tiny local groups that are working with some of the most disadvantaged and those marginalized groups of people. How are we going to work with those to make sure that we can support them in getting to the front of the queue and getting to the queue,
Yeah.
finding their way around the system. That wayfinding is huge for people with English as second language, low
Yeah.
health literacy.
Yeah. So it is one of the things where we need to be saying it's important. Again, it's an expectation, it's a requirement of boards and leadership teams to actually do that and find ways of doing it. There's a skill in doing it. So you'd expect, going back to that point about having the right people in the room, that you've got someone in the room or some people in the room who actually know how to do that and have the networks and the structures and the approaches that can actually engage with people properly and appropriately so that the voice can be heard. And as I'm talking, the thing to avoid is this tokenism thing. Well, we meet with them 3 times a year, and
Yeah.
I've done a report and I've said I've met with them and it's fine and everybody loves each other and all that, but we actually haven't dealt with what was actually going on. And then also it'll be different in different places. The presence of the groups will be different. The complexity of them will be different. They'll be oriented to what the specific issues are in those communities, whether that's deprivation or ethnicity, or there's a big community that's quite unusual and only really exists in that community, or a few others. So you have to. It is one of those things where we'll set the direction, expectation nationally. Increasingly, when we're judging whether organizations are doing well, we'll be looking at the skills and competencies in the board and in the senior team. Have they got the right people and approaches? And then over time, we'll be tracking more of the metrics on satisfaction and confidence, experience, to see whether it's actually working.
So a lot of, and I'm assuming, and I know we can't say more about this till we actually see the plans for neighbourhood health tomorrow, but they've been pretty heavily trailed. The neighbourhood health is coming, but I assume then in the vision of neighbourhood health that we're then thinking about those social and structural determinants of health as well. So somebody in there is like housing, education. Is your vision that all of these groups can come and work together to look at the whole person?
Absolutely. So a big part of what we're going to try and do is to again, the plan will give that message, but then help people to work together across boundaries and understand that all these, I mean, everybody understands it anyway. We're just not being very organized about it, but housing's a big thing, education's a big thing. Sometimes the police are a big thing.
Yeah.
Having all the partners engaged. I'm trying to resist the thing about saying all working physically under the same roof.
Yeah, no, fair enough.
But it does help. It does help if you're bumping into each other regularly and you have the ability to meet regularly and or know that you've had an interaction with someone you're a bit worried about. And I think next time I see that person from the housing association, I want to talk to them about this individual. And so there is something about the physical facilities helping, increasingly the technology helping, so people can share data, intelligence, interact with each other, etc. In a test, I've just done a media thing around the corner, and this is a test we used to use in a previous role was you should be able to watch it from the window and not tell who's working for who, because they're just all doing what they need to do and they're getting
That's
on.
nice.
They've got a purpose, and they might work for 5 different organizations, but it doesn't matter.
Yeah, no, and I think that's where we need to get to, because it's, it is more than NHS, isn't it? Health is much more than NHS. But we've got to move on, because I've only got you for less than 15 minutes. So, Jim, one of the things that we know, like, we're all talking about social care. How are you going to do this without social care? Until social care is properly integrated, will patients still struggle with kind of fragmented patient journeys?
We are really dependent on each other. There's absolutely no doubt about that. And often you actually come to understand where the boundaries are only when you need to. So it's usually at a time you've got somebody who needs to go into a home, or they're trying to be discharged, you're trying to get them discharged, and you find out that this bit is provided by the NHS, this other bit's provided by social care. Some of it's free, some of it's not free, and it's really complicated, isn't it?
Yeah.
We all know we're totally dependent on each other in lots of ways. but we have to understand also that social care hasn't got lots of money. It hasn't done massively well in the spending review. So until the big review of social care has taken place and we've reset that model in the system, which will take, it's obviously a long way off from where we are now, then I think we're in a pragmatic world where health leaders with council colleagues will have to work out what the business case is. So if that means, which we've, I've done before and got quite a bit of criticism a couple of times for it, but if you've got to do something, that might mean you're spending what's strictly health money on supporting the social care system because there's a bigger value. It might allow you to free up capacity to do other things that you need to do. It's about the business case, and it's about the pragmatism, and it's about the relationship. And on that, so, Paul Hanson, who was a colleague I've left behind in Newcastle temporarily, but used to run North Tyneside Council, I remember telling me at the height of COVID, you make your friends in peacetime, which I'll remember for the rest of my life. So it is absolutely about people just working together, and but there has to be a tension in that as well. So it's not just about everybody holding hands and singing Kumbaya, because there's going to be some edge in it. If things aren't working properly, you need to be confident to be able to say that without everyone falling out about it. But it takes a lot of explaining where the boundaries are. If it takes a lot of explaining, we're going to have to be pretty pragmatic to get what we need to get.
You just put Kumbaya in my head now, so I'll be the rest of the day, but we do need to be much more proud. Jim, okay, so why did you take on this job? That's not actually the question, but it's feeling pretty big right now. But you have chosen to take on this leadership role, which I think is during one of the most challenging times in NHS history. What gives you that genuine hope and optimism about the future?
So the hope and optimism is honestly born out of evidence and experience of I've been in the service a long time. I actually started my career in local government, so it's a long time ago, but I sort of understand how that bit works. But I've been in the NHS 30 odd years. Throughout that time, I've worked with amazing people doing mind-boggling stuff, sometimes very technical stuff, sometimes what doesn't look very technical, but just incredibly compassionate and amazing for the individual and the family and etc. In this last few months when we've been developing the 10-year plan and in the national thing, it gets very technical very quickly and very remote. So every now and again, get out and see people. And I remember I was in Bolton a few weeks ago, and we'd spent a lot of time talking about neighbourhood care as though it was something that's miles off. Nobody's doing it. It's a new thing. How we're going to get everyone to do it. And then I went and saw it and it reminded me that I'd left it behind, and then all these people are doing this. We're just not doing it as systematically and as structured and as consistently as we want it to be. So, I think, and when I read the article the other day, I felt it was a bit critical. I didn't mean it to be critical of colleagues in the NHS, because the NHS is populated by amazing people who are trying the very best. We've just made it hard for them. And that's the bit that we can hang on to. I've never met anyone who's gone in the NHS with no purpose or without a really strong desire to serve people and to look after people and to care for people.
And we hear that from patients regularly. We talk to patients about the impact of waiting, and patients, we hear some really harrowing stories about the impact on their ability to live their lives to the full, to have relationships, friends and family, financial impacts, all the things that I know we've spoken about. But majority of patients will say, once I get to my healthcare professional, there still is trust. So there still is a massive amount of hope. And I, as a patient association, I always want to talk about partnership between patients and professionals. So, and we can't do that unless we genuinely want to work together.
Absolutely.
So that's really important to me. So, Jim, you're coming back to see us in 5 years' time. What will success look like?
Well, wow, it's a good one. So success, I mean, 5 years is a long time. So you think back 5 years, well, we were just out the first round of the first wave of COVID, weren't we? So it's mind-boggling, isn't it? Thinking what can happen in 5 years. I would hope if I come back and talk to colleagues in 5 years' time, the system will be less stressed. We'll be talking less about failure and distress and the disconnect and all the stuff that we've been talking a lot about recently. We'll see large chunks of the ambition that's written in the plan actually in reality delivering for people. We'll see patients and families happier about what the NHS is doing for them. Staff who are happier because they're able to do what were trained to do and have the space to do it as well as they can. And will the big success I think is you'll see a bounce in people's steps, that they've got the energy back and they've got the hope back built on. We've taken some small steps in this year and next year, etc., to steps towards recovery. But the energy and the enthusiasm, the ambition carried them on, and it's given them confidence to go on and beat the world. And that's what we'll do.
So we're out to beat the world.
Best healthcare system in the world again.
Best healthcare system in the world.
Yeah.
Cool. I like that ambition. But also, as part of the best healthcare partnership in the world, how would you envisage that partnership working, that, you know, getting patients involved at the very beginning, design and delivery of services in that overarching, but then that shared decision making, that individual consultation where patients are genuinely listened to?
So it'll be more normal. It'll be, I mean, I don't know who you've got on the call today, honestly, Rachel, but these sorts of things will be mixed. I'll be less talking to NHS leadership community without having patients and families and community partners in. It'll feel more mixed. It'll feel more joined up. It'll feel more engaged. We'll be able to see that there's better alignment, that it's embedded in processes and organizations, it's visible in the data, in the transparency. And if you take, for example, the aspirations on patient power in the app, we'll be thinking less about the institutions owning those things, and they're actually owned by all of us. They're owned by the patient. The institutions have access to it. It's not the other way around. So we'll see some big shifts in all of that, and hopefully what we'll see is that tangibly represented in the data that shows that people have seen that we've heard, they've seen that we've set out a plan, and they've seen that we've taken action, and it's shifted experience.
Shifted experience. That is great. So, well, basically, Jim, we are doing partnership in practice on this call today, because I can see it from the webinar chat. We have a lot of your colleagues on the call and an awful lot of patients on the call. So a real example of how there are other healthcare professionals, but it's real people out there who really genuinely want this to work for patients, and those patients who are not experiencing the great service, and those people. And I think I agree totally with you that let's not talk about inequalities. Let's do it so the patients have a better experience. So in talking to some of the department in the last couple of days, this is my last question. In talking to some of the departments in the last couple of days, I've kind of been saying, well, yeah, we have a plan out tomorrow. That's a vision. That's great. The real work starts on Friday in implementing this plan and making sure. Is there anything you want to say to patients in your last kind of 3 minutes of the webinar about how we're going to do that with people?
You've asked some good questions today. So we will.
Yeah, you knew I would.
So we're quite well advanced in how do we get the leadership engaged in what we do next. You've reminded me, and this has reminded me when we're doing this next Thursday, to be clear that local leadership needs to be engaging with their local community groups, patient groups, voluntary sector, etc. as they're taking the plan and distilling what what we're going to do about it. So you're absolutely right. I'm expecting Friday morning I'll be getting harassed about why we've not delivered certain parts of the plan, yet. So that machine will
Yeah,
kick
yeah,
in. We're
yeah.
going to have this conversation amongst the chief exec community next Thursday to say this is what we think we're going to do. Let's do it together. These are the things that are going to happen in the next few months, and we will make a very strong plea for everybody to work together with their patients, community groups, get the system set up, make sure you got the right people in the room, use the mechanics that work, and shape it together. Because neighbourhood care is going to be different in Blythe to wherever, Haringey or, West
And
Birmingham.
so it should be,
Yeah, absolutely.
reflecting its neighbourhood.
So it's going to have to be taken, adapted, nuanced to fit the local community. And it's been really timely. As I said at the beginning, I mean, it's a compressed day because there's a lot going on. Tomorrow's a lot going on, etc. But really timely for me to keep me grounded on remembering this and making sure that this is incorporated in our work next year.
Brilliant. Well, you can rely on me and the Patient Association to keep you grounded in how important this
Absolutely.
patient partnership is. But Jim, I suppose one last plea and then a huge thank you for spending the time with us. But one last plea is not to forget the voluntary sector in this and the role that they do with small, especially your local voluntary sector, working with those people who are marginalised
Absolutely.
across the whole health spectrum, just not the NHS, because you'll get real amount of power and trust through doing it like that. Jim, thank you so much. I've really enjoyed it. I hope my questions weren't too difficult.
No, thanks very much, Rachel. That was great. Much
No,
appreciated.
thank you. And we have 2 more sessions coming now, which tomorrow, which is energizing the 10-year health plan through patient partnership, and then championing patient voices and healthcare campaigns. So Jim, I'm going to let you go because you have a lot. I know you're back to back in meetings.
Yeah.
So thank you. Getting really nice thanks in the chat as well from people about your honesty and transparency in this meeting.
Great. Thanks very
So
much.
much. See you soon.
Bye.
Bye-bye. Thank you all for attending, and I hope to see you at our last 2 events this week. Many thanks.